I'm just going to start by acknowledging that the information on this GPSC Billing Education webinar on MSP Basics tonight on Thursday, March 11th, 2021 is current and up to date. It may be subject to change, but please defer to the MSP payment schedule and or the GPSC billing guides should you have any questions. I'm just going to check our chat box. And seeing no questions there, let's get started. Wendy, Kathy, the floor is yours.
Hi, I'm Dr. Wendy Amuro, and welcome to MSP Basics. So my disclosure, at this point in time, I'm a locum in Richmond after being a solo practitioner there for 24 years. I am presently and have been for the last couple of years answering billing questions for BC Family Doctors. I'm a present member of the Tariff Committee of Doctors of BC, and formerly I was a member and then chair of Patterns of Practice Committee. I was on that committee for 20 years. I was also the Doctors of BC rep to the Audit and Inspection Committee for 3 years. Next slide, please.
Hi, everyone. I'm Kathy Cleland. I'm a family physician in the Tri-Cities area. My clinical work is in focused GP maternity and newborn care, as well as outreach care to our local First Nations primary care clinic. My day job is I am the medical director for primary care at BC Cancer. I have worked extensively over the last, I'm going to say, decade and a half at preparing and delivering practice management sessions with Jewel, which is an arm of the Canadian Medical Association, as well as independently. And I've done billing sessions with the GP Services Committee, BC Family Doctors, the UBC Practice Ready Assessment IMG program. That's quite a mouthful, I have to say, and UBC CPD. I'm also on the board of directors for BC Family Doctors. In the past, I was executive director and president and a number of other things. So like many of you, as a generalist, we have many balls in the air at any given time, and that's been a part of my my background as well. So Wendy, I shall hand it back to you. Katrina, next slide, please.
So let's go over the agenda. So we're going to start out with general information. Then we're going to go on to a general preamble review and the basic billing rules. And then we'll go on to the basic visits, the 0100 and that equivalent series, the counseling, the 00120, the complete physical, the 00101 series. And then we'll talk about when is a visit more than a visit, multiple services and procedures. And we're going to finish up with COVID-19 and the respiratory related codes. Next slide, please. So basically, you know, it used to be Society of General Practitioners of BC, and just before COVID started last March, they rebranded to BC Family Doctors. Next slide, please. So if you are a member of BC Family Doctors, a really good place for you to go, and your MOA also can be registered to get answers to billing questions, is the Simplified Guide to Fees, which is found on our website. And it's for members only. So everything we're going to cover today is on the BC Family Doctors website. And for this presentation, whether you're a member or not, you'll be able to log in now to be able to access the Simplified Guide to Fees during this webinar. So your temporary username would be temp tutorial. Your temporary password is there. So if you are not a member of BC Family Doctors, it's available when you renew your annual membership with Doctors of BC. You just select section of family practice, and you can join both BC Family Doctors and the Doctors of BC. Next slide, please. So the disclaimer. So the Medical Care Protection Act requires that every physician maintain such records as may be necessary to establish whether he or she has provided an insured service to a person, that it was medically necessary, and that the service billed to MSP was the service a physician provided. This is really important if you ever have an audit. If you have billed things and your records do not establish that you provided that service, you may have to pay it back. So as presenters, we've made every effort to ensure that the examples presented represent best practice billing. However, all physicians are personally responsible for their billings, and you need to read the BC MSP fee schedule preamble. There's both the general preamble and the family practice preamble, and be responsible for meeting all criteria for the appropriate billing of the services they provide. All of the service and documentation criteria elaborated in the schedule of benefits must be provided and documented for appropriately submitting the answers to the following billing examples. Next slide, please. So we'll next slide, please. Okay, so we're now going to go on to the general preamble review and the basic billing rules, which may seem very boring, but they are very important to read. Next slide, please. So as I said, there are two different preambles. There's the general preamble and then there's the specialty preamble. So the general preamble complements the specialty preambles in the schedule. The intention is that together, the preambles assist medical practitioners in appropriately billing insured services. If, however, there is an inadvertent conflict between a fee item description, a specialty preamble, and the general preamble, the interpretation of the fee item description and or the specialty preamble shall prevail. Next slide, please. So the purpose of the general preamble, the schedule is a list of fees approved by the MSC and payable to physicians for insured medical services provided to beneficiaries enrolled within MSP. The preambles provide the billing rules under which the fees are to be claimed. These rules are a roadmap designed to clarify the use of the schedule. Next slide, please. So the basic billing rules. All benefits listed in the schedule, except where specific exceptions are identified, must include the following. So direct face-to-face encounter with the patient by the medical practitioner, appropriate physical exam. So of course, now with COVID, there's also the telehealth visits. So any inquiry, including the review of the medical records necessary to arrive at an opinion, appropriate care, arranging for any related assessments, procedure, and or therapy, arranging for any follow-up care. So discussion with and providing advice and information to the patient or the patient's representative regarding the patient's condition and recommended therapy. No additional claims may be made to the plan for such advice and discussion. An adequate medical record of the encounter, that's so important, that appropriately supports the service being claimed. Next slide, please. So the in-office services. So a lot of these are now provided by telehealth at this point in time, but the majority of family practice in-office services fall under three categories. The office visits, which are partial exams, the 0100 series, the counseling, the 00120 series, and the complete physical exams. So we know that for all three types of services, the fee value depends upon the age of the patient. And so the value is higher for patients under 2, and then it increases with each decade from 50 onwards. So they're giving you an example of that in the little box, age differentials in all three categories. As you know, less than 2, 2 to 49, 50 to 59, 60 to 69, 70 to 79, and then 80 and over. Next slide, please. So again, this is just a screenshot of what you would see if you went into the simplified guide to fees. So there's all these different tiles. So the COVID-19 pandemic, the virtual health, and the impact on practice. And there's a specific tile strictly for billing during COVID-19. Next slide, please. So telehealth service. So telehealth services for family practitioners fall under two similar categories. So the 0100 equivalent series is the 13X37. The counseling 00120 equivalent series is the 13X38. But the complete physical exam, you have to do an in-person exam of all systems required. So there's no telehealth equivalent to the CPX. And again, for the telehealth visits, they also have the age differentials. Next slide, please. So there's been a change to the definition of the telehealth service. Prior to the pandemic, telephone was not included in a telehealth service. So in response to the COVID-19 pandemic, MSP has expanded the definition of a telehealth service to include telephone. Whether this is going to be ongoing or just temporary, we don't know at this point in time. So telehealth service at this point in time is defined as a medical practitioner delivered health service provided to a patient through the use of video technology or telephone. And that's been effective since March the 13th, 2020. Use your professional judgment as to whether using video or phone is clinically appropriate without the physical exam. Note it says medical practitioner delivered. These telehealth fees cannot be delegated to a nurse and billed to MSP. Just as equivalently, you could be, when you do face-to-face, you cannot delegate an office visit to a nurse and bill it to MSP. Next slide, please. So duplicate services and multiple visits. Duplicate services means same day, same location. So you use the submission code D if it's the same fee code. A different time, obviously it'd have to be a different time, such as if the condition worsens, you have to indicate the time. It's really good idea to put an E-note in. It's going to help you get paid. Same time, such as 2 lacerations, single claim, note record of the duplicate nature of the services. Multiple visits, same day, different time, different location, such as office first, then the ER. So you've got to use your correct location codes and your time and note record. Multiple services, same day, same time, different services, such as a visit and a procedure, two different procedures. So that would be for equivalent, say if you did check somebody's blood pressure, 0100 age appropriate, and then you also did a PAP, the 14560 age appropriate. That would be a common example of that. Bill the higher value at 100% and the lower value at 50. One tray fee only, highest value is billable regardless of multiple procedures. Tray fee always billed at 100%, even if the procedures are billed at 50%. Now, talking about these duplicate services, multiple visits, there is, Katrina's got a link to it. It's worthwhile to actually have a look. There's MSP tutorials, which you can access through the MSC site, and they really delineate these very well. Next slide, please. Okay, so we're now going to go on to the basic visit, all 100 and equivalent series, and we'll switch over to Dr. Clelland, but we do have a question. Did you want to answer that question, Kathy?
So the question around the time, I'll come to that when we get to the multiple services and procedures when we get to that section.
Okay.
Perfect. Thank you, Wendy. So first of all, we're going to start off with the visits and examinations. This is taken directly from the preamble to fees. It's really important that you understand what is in the preamble to fees because it very much describes what is expected and what needs to be documented. So your office visit is considered a partial or regional examination. I personally still to this day use the SOAP formula when I'm documenting in my chart. Subjective, objective, you know, the plan and the assessment and plan. So I still use that no matter what it is I'm seeing patients about. So you do need to include what is the patient there for that day. You need to ask about the questions, what are the other symptoms they may have, and examination of that system, depending on what it is, so that you can confirm what you're finding and how you came to your diagnosis. Then you also have to document the advice or information that you've given them, any treatment you've offered, prognosis, any of the return part. So as an example, just saying someone has come in with a headache, putting down headache, exam normal, prescription for X is not adequate. You need to actually document what your examination was, whether you did a CNS exam, whether you did a musculoskeletal exam, whatever you're thinking about or whatever you've done, you need to document. So the biggest way to protect yourself if ever any audits come up is document, document, document. So the questions the questions that are in the side window right now are about multiple services, and that we will get to those when we get to that section. I'm not going to deal with them at this point in time. Next slide, please. So the real thing to remember is that the billing for an office visit is just a visit, regardless of the number of complaints. A patient could come to you with a list of 10 different things. And what I always do is, I ask them, I say, what are the top 2 or 3 things on this list that you would like addressed today? Because we aren't going to have time to go through all of these. I've already scanned it though, because sometimes what the patient thinks is their top 3, and then you see this thing down at the bottom that talks about chest pain, but they didn't indicate that's a top thing. I'm going, you know what? I think we probably need to talk a little bit about this chest pain, because you don't want to miss something that could be very significant. So, when you've got someone who's coming with multiple things, you have to document all of the things that you've dealt with, what your findings were for all of the things that you're dealing with, and what you've said, done, or prescribed for all of the things that are part of that visit. So that's the best way to deal with the multiple condition list. You cannot bill multiple 0100s. It is a single 0100, whether it's one thing they're there to talk to you about, 2 or 3. The college frowns on anyone who has signs up that say one issue only. That is absolutely not ethical, and it is inappropriate. Both the college has guidelines on that, and so please do not put yourself in a situation where you could get a college complaint because you've been restricting patients to a single complaint. That being said, again, it doesn't mean you have to deal with 10 complaints at one visit. You can prioritize and bring them back for things that you and the patient feel are maybe not the most important things right at that time. Next slide, please. So this is the 0100 series. When Wendy showed the slide that sort of showed the pattern of how the fee codes came about, there is actually a logical pattern to this. You will notice that other than the 0100, which is our base visit, and for, believe me, the longest time, all we had was the straight 0100, no matter what age people were. When we started adding in other ages, the second digit became the age-related code. So 12 is under the age of 2. 15 are the 50-year-olds. 16 are the 60-year-olds, etc. The middle digit for all but the 50-year-olds is a 1. So the 100 is an office visit. Unfortunately, when we brought in the 50-year-old age differential, the 15100 already exists. You'll see it later on when we get to the laboratory component. 15100 is a glucose test, and because the lab codes had been existing for a long time, MSP felt it would be less confusing to bring in a completely new series of codes rather for the 50-year-old visits, rather than try to repurpose other codes, the lab codes instead. So the in-office 50-year-olds, that third digit is a 3. Then the last 2 digits are for visits are 00. You will see when we get to the others. For counseling, it's 20. For full physicals, it's 01. So there is actually a bit of logic to how the numbers were assigned. Next slide, please. So of course, a year ago, almost exactly a year ago, we all know how the world shifted. Our reality tilted, and we were all advised to stay home or not be seeing patients other than those where it was really truly medically necessary that they needed to come in for an examination, something that you couldn't do virtually. And so the age differentials for telehealth ended up being brought in because our old telehealth visit, the single 13037 was a weighted average value based on all of those age differentials. But that doesn't really help when you have an 80-year-old in a virtual visit that takes you much longer to do than a 20-year-old. So the SGP at the time, now BC Family Doctors, went back, actually no, it was BC Family Doctors by that time, we'd already done our name change, went to MSP and advocated for an age differential very similar to what we have for our office visits, and they are paid at the exact same rates as the office visits. So even though they are called in office, no matter where you as the provider, as the physician are doing the visit from, it is still the same code. So it's just in office because you're not in a hospital or in a facility. Next slide, please. So these are the telehealth visits. As I said, again, there is some logic to this. All of the 0100 equivalents end in the numbers 37. The first numbers 1, 3 are just part of this bit. The age part again is the third digit, 2, 4, 5, 6, 7, and 8. So the 4 is the ages 2 to 49. The T, you do not have to ever submit the letters. When you see any fee code in the fee guide that has a letter before it, that is kind of a technical thing that MSP uses to identify it. So T stands for temporary, but what you submit to MSP is just the 13237 or 13537. So whenever you see a letter before the 5-digit number code, for billing purposes, you do not need to think about that. In your office software, it will not include the letters anyways. It will only include the numbers. So again, here are the age differentials for the telehealth visit. So think of it as the same as your office visit, only by telehealth. The rules and regulations, if you have not had it, if you're not certain around how to do telehealth visits, Doctors of BC website has some great information around how to conduct telehealth visits. What are the things you need to think about? And you do need to make sure that at this point in time, obviously we are well past June 1st of 2020. These are the codes you use for the telehealth visits. Next slide, please. So we've got our first poll here. And when I get through the polls, then I'm going to look and see if there's any, we'll see if there's any questions that we need to answer. Some of them are things that may be answered later on. Others are answered in other sessions. So the case of Tasha Wellwoman. So Tasha Wellwoman is a 25-year-old law student at UVic. She comes to the office to discuss contraception. So you talk to her about the risks and benefits. You find out whether she's got any family history of DVT or embolism, any history of or personal history, blood pressure issues. And after this conversation, Tasha makes the informed choice. You write her a prescription for your birth control pill. What fee code are you going to bill for this? So this is our poll number 1. If you can click on the which you think is the appropriate code to bill for this, we'd like you to do that, and then we will move on to the answers. Katrina, I'll let you decide when you're going to cut off the answers. I know you wait a couple of seconds, usually about 30 seconds or so, and then we get the responses back. And the 0100 is the correct answer. Wendy is going to go over why, when she does the counseling part, she is going to go over why the 0120 is not an appropriate code to bill for this example, but the 0100, the 1530, I would probably, you don't have a 50-plus-year-old law student who's asking about contraception, because by that time, most of them are contraception, no. You know, all the perimenopausal symptoms, yes, but not contraception. You can go ahead and close that poll now then, and we'll go on to the next slide. But of course, we're in COVID. And so that's a situation where you wouldn't need to see Tasha in person at that point in time. Now, you may want her to check her blood pressure at you know, if she has a home blood pressure monitor. And they can't do it at the pharmacies anymore because those are all closed. We used to be able to ask them to do that. I mean, the only thing that you might want to have documented as well at some point in time is what her blood pressure is. It doesn't have to be at before you start the contraception, if there's no history and no family history. But at some point in time down the road, you are going to want to see Tasha in person in order to document that there is no concern there. So for the most part, you're going to have this conversation with Tasha via telemedicine. Next slide, please. Oh, we missed it. There should have been, so the telehealth visit for her would be, if we went quickly just back to the telehealth numbers, one more there. So she is in her 20s, whoops. And so she would be the 13437 for that telehealth visit. As I said, the value is exactly the same as what you will be paid for an in-office visit. I'm taking a quick look at the list of questions. There's one there about, is there a code if dealing with more than one complaint to bill for this extra time and effort? No, there is not. Whether it is one complaint, 3 complaints, or a dozen complaints, a visit is a visit is a visit, and only billable as an O100. Wendy will go into the difference. Yes, the counseling visits are a time-based visit, or have a minimum time requirement, I should say, but it is not simply about, it's not purely about just the time. And I'll let Wendy talk a little bit more about that, because we talked earlier about asking people to prioritize which of their list of things are the top 2 to 3, and then that's what you would deal with, and then bring them back for additional an additional visit to look at any other things. Any other questions there, Wendy, that you think I need to answer?
Well, I just wasn't sure. I'm confused about the question where it says, is it for the physician or the clinic? And how does it work when you work in more than one clinic? I'm not quite sure what they're asking.
It's kind of coming in sort of the multiple services bit. So I'm not sure. The only one that really has a specific concern about that really is going to be around the O120s. And as I said, Wendy will talk about that, the questions about tray fees, anything and everything to do with multiple services and with procedures, we will be dealing with later on in this session. So we'll wait until that point. So go ahead, Wendy. I will hand it back over to you then for the counseling section.
Okay, so the 00120 series counseling, this is really important because this is one of the major things that docs seem to get wrong, and it's something that it's a major audit. It's a major reason why they do audits. So according to the preamble, counseling is defined as a discussion with the patient, caregiver, spouse, or relative about a medical condition which is recognized as difficult by the medical profession or over which the patient is having significant emotional distress. And they give the example of including the management of malignant disease. Next slide. So counseling, to be claimed as such, it must not be delegated because it's a visit, and it must last at least 20 minutes. So it requires a start and end time, both in your EMR charting and in the claim, both to MSP, and also there's the GPSC counseling fees too. It's not to be claimed for advice that is a normal component of any visit or as a substitute for the usual patient exam fee, whether or not the visit is prolonged. A lot of people get confused and think if I spent 20 minutes, that's a counseling. No, it still has to meet the criteria for counseling, such as 00120 must not be used simply because the visit takes 20 minutes or longer, such as in the case of multiple complaints. Next slide, please. So the counseling codes are also not intended for activities related to attempting to persuade a patient to alter diet or other lifestyle behavioral patterns. For this, when done as part of a personal health risk assessment, use 14066. Now that's a GPSC fee and it will be talked about in another webinar, but the 14066 is only for 4 very specific diagnoses. 14066 is billable via telemedicine as of June the 1st. Nor are the counseling fees generally applicable to the explanation of the results of diagnostic tests. Next slide, please. So when is it appropriate to bill 00120? So psychiatric care, counseling for a significant grief reaction, and when a life-changing diagnosis has been made, such as diagnosing insulin-dependent diabetes in a child or a life-limiting malignancy. Next slide, please. So this is so important for the 00120. Document, document, document. So documentation must include the effects of the condition on the patient to prove that it was causing significant emotional distress, as well as advice given and service provided. Always make note of the start and end time of a time-based fee in the chart. This doesn't apply just to the 00120, any time-based fee. And start and end times are also required on the billing submission. Next slide, please. So this is an example of this is the different individual counseling in offices. So Kathy's reviewed this pretty well for the All 100 series. So it's the same thing here. Next slide, please. So out with the old. So it used to be that the telehealth counseling visit, strictly one thing you could bill, the 13038, and just as with the telehealth equivalent to the office visit, we now have age differential fees for telehealth. That was effective June the 1st, 2020. Next slide, please. So the telehealth counseling, it's the old one, so it is equivalent to the 01200 series. And again, it's for a prolonged telehealth. All the same rules apply for billing the counseling by telehealth as apply for billing the counseling face-to-face. Next slide, please. So second poll, the case of Ms. Smith. So Ms. Smith, she's a 50-year-old who attends your office requesting a prescription for sleeping pills. She becomes tearful when you ask her to describe her sleep problems, and she tells you that she is feeling overwhelmed. On further discussion, it becomes clear that she is experiencing a lot of anxiety, and you wonder if there is underlying depression. You spend the appointment reviewing the symptoms of anxiety and depression, and you confirm the diagnosis. You provide supportive psychotherapy and ask her to return for follow-up in 1 week. You've spent 23 minutes with Ms. Smith. What would you bill? Next slide, please. So again, here's a poll. So what code would you bill? The 15300, the 13538, the 13038, or the 15320? We'll give you a few minutes to make your choice. Okay, so the majority of you picked the correct answer, the 15320. You certainly could bill the 1300, but you've done the work, so you should be billing the 15320. The 13538 is a telehealth visit, and as is the 13038. Next slide, please. So poll number 3. What would you bill if the same visit, the same counseling visit was via telehealth? What fee code do you bill? So I have to be honest, can we go back to those telehealth counseling visits? Because I
It's
think it is about,
13538.
it's the 13538. Okay, so the majority of you picked the right one, 83%. And the 15320, you would not bill that because you've done this via telehealth, and there is a corresponding telehealth counseling fee. And the 15300, that's an in-office regular visit. And the 13038, is that the regular telehealth in-office visit? Anyway, you wouldn't bill that either. Okay, next slide, please. So we'll review some more of the questions. Katrina, I'm having trouble moving the questions to, I know there's 15 questions there now, and I can't see.
I'll read out the questions that are pertinent to this for you, Wendy. How's that sound?
So that'd be great.
Okay, excellent. So the first question that's pertinent to this is that 20 minutes for counseling 20 minutes of face-to-face, or does it include charting?
No, it's 20 minutes of the time that you spent with the patient. The charting's over and above. It's not included in the 20 minutes.
The next question, what is meant by psychiatric care of 0120? If a patient is anxious or depressed and you counsel them at that point, is that appropriate?
Yes, and remember, document, document, document.
Perfect. I see this is moving around, and so I'm not, Katrina's moving things over. So then it does, then I'm going, my eyes are going wonky here. How is counseling 0120 different from mental health management? So I'll take a quick on that one. The mental health in what were the GPSC codes, the mental health planning and management fees. The 14044 is the extra 4 counseling visits you get once you've done a mental health planning fee, but the details of that will be provided in a separate session.
But generally you want to use up your 00120s before you then go on to do the mental health ones.
Yeah. Then the next question is, what if your counseling was 42 minutes? Can you bill 2 of the 0120 codes?
No, no matter how long you take, it's just the rules say you can only bill 1. You can only bill the 1 visit.
Yeah. And then the next question actually has to do with when we're talking with the parents of a child. How do you counsel a 1.5-year-old? Because of course we do have the counseling visits for under the age of 2. And so maybe you can go into a little bit about how MSP wants us to bill, not on in the case of a child, they still want us billing on the child, even though really the counseling is with the parent.
Right, that's
true. Child.
Yeah, that's true. The child's got to be there. So as long as you are counseling, you're right, 1.5-year-old. I don't know how many counseling visits you'd be doing there, but that would be one of the things that probably would be appropriate if the child was just diagnosed with insulin-dependent diabetes, and you're going to spend over 20 minutes talking to the parent, but about the child and going forward with that.
Yeah. And then the how do you bill your charting time?
You don't. It's included in the visit. As in, it's included in the payment for the visit, but it's not included in the time to calculate the time that you spent on that visit.
Yeah. The next
you
question
never get paid for charting.
Yeah, it's all included as part of it's expected as part of what you're being paid for.
Yes.
The question is, if the patient has anxiety and depression, why not bill the 14043? Again, that is a separate talk. That is a planning fee, and we're not going to go into any details about that. You may end up doing a planning fee on that patient, but you'll need to sign in for I'm not sure, Katrina, which session that is, because I can't remember what is 2 and what is 3, but it's be one of either 2 or 3 in the series.
And I believe that you can't bill those extra counselings until you've used up your 00120s.
That's correct, and you've submitted, but this was specifically about the planning fee, not about
Yeah.
But regardless, please tune in, sign up for the session that's going to cover that in detail. Mm-hmm. How many times a year can you counsel a patient regarding an issue?
So the big thing to remember is that the 00120, there are 4 visits. There's 4 of those you can bill per year, but it's not per physician, it's per patient. So you may go to bill your 4th 0120 and be rejected because the patient has been somewhere else and someone else billed an 00120. So that's really important to know. Like if you have a locum there and if they're doing the work, they should bill it, but it's only 4 per patient per year.
So then there's a question that has to do with locums
Mhm.
and counseling, and how do you keep track of all the counseling sessions you use up? But again, as Wendy said, the counseling visits limit is per patient, not per physician. The next question that came up is, well, what happens if someone has used up their counseling for the year, but you don't know when you bill an 0120 anyways?
You won't get paid.
You will
You'll
get
be
paid.
rejected.
MSP, it won't be rejected actually, Wendy. What I have found is the MSP downgrades it
Yes.
and pays you at the rate of the 0100.
Yeah, you'll get paid, but
up
you
with-
won't get the 0120.
Yeah, you will not get paid an 0120. You will get paid the rate of the 0100.
And then if you think you're going to have to do further counseling visits, then that would be the time to do the mental health management. And so you have access to the other 4.
There's a question about house calls, but we're not dealing with that today.
Nope.
That'll be at a separate session.
So is that the last question, Kathy? Because then I'll turn it back
That is
over
the
to
last
you.
question. There is one that's actually directed at me. Directed to Kathy. How do you bill for seeing regular cancer patients, as counseling is often an integral and involved part of the visit? You know, it is the same rules that apply. If your patient needs counseling as a result of their cancer, whether it's the cancer itself, the cancer's impact on their life, the cancer's impact on their marriage, the cancer's impact on their work. If you are providing counseling under the preamble definition of what counseling is, you still just bill an 0120. You still only have 4 in a year. And that is a part, unfortunately, that is the restrictions that we have to live under for that. And let's see here. Now there's a couple others come up here. How many do you have to use up? You've already covered that. Can you bill a patient privately for counseling if it can't be paid for it? The answer there is no. If it's a medically necessary covered service, you cannot bill the patient, or they can definitely complain about you. It'll go to the college, and you can get some really pretty significant bad news coming from the college if you try to bill the patient privately. For when you are enrolled, opted into the MSP system, you cannot bill the patient privately for what is considered a medically necessary service. Again, the mental health management, we're not talking about that because that's under a different webinar. While 4 may seem to be a low number, it is what it is. That is a historical thing, and so far we have not had any success in changing that. So we're not going to answer anything to do with the 14043s or the GPSC mental health fee codes themselves. So that you will need to come back at the appropriate session. So now we're going to move on to the complete physical. So if we can go to the next slide. So thanks, Wendy. Now it's my turn. I don't have a lot of slides here. Most of what I'm going to do is just actually talk about the first couple of slides. So the 0101 series of fees, the complete examination. As Wendy indicated earlier, there is not a virtual equivalent because you can't do a complete physical virtually. It has to be your hands, your ears, your eyes that are doing the examination. You must include a complete detailed history. Now, many of us, both in old paper charts, but also within the EMRs, you have a kind of like a face sheet equivalent. You quickly can review, has anything changed about your family history? Have you had any new surgeries that I wasn't aware of because the surgeon forgot to copy me on the operative report? So those parts of it are already within your EMR, and it's really just an update. So you're not starting from square one, but you have to do a functional inquiry. But a complete physical examination is definitely, as you can see by the bolded, all parts and systems with special attention to local examination where clinically indicated. So the I remember when I was teaching once to some medical residents, and one of them asked me, well, my preceptor said that I could bill a complete physical as long as I examined at least 3 systems on the patient. The answer to that is no. It is head to toe, everything that is appropriate for that age and sex of the patient. So in a 90-year-old woman who's had weight loss that you can't explain, you don't actually have to do a pap test because they're not indicated at that stage. You're probably not going to be able to do a pelvic exam because that it'll be a very challenging exam to do, but you're going to examine every other system. So it is truly a head to toe of everything that's appropriate for that age and sex of the patient. You must document all the findings, positive and negative. So again, I used to, in my old paper charts when I was in practice in Kelowna, and even now in an EMR, I still set my documentation up, and some of the EMRs actually set it up for you in the SOAP kind of way, so that my assessment part, I still start off with what are my general vitals, head and neck, chest, heart and lung, heart, working my way down the body, and I will still document exactly the way I did when I was a resident and a medical student in the hospitals. Have your differential diagnosis, a provisional diagnosis, and any advice or information that is given. Next slide, please. In BC, and this is not the case in all jurisdictions, in BC, annual physical examinations are not an insured service or evidence-based intervention as a screening kind of procedure. So someone coming in for a regular annual checkup is not appropriate. Medically indicated means that patients with chronic diseases, when the guidelines recommend full physicals at any kind of an interval. For example, patients who have insulin dependent diabetes, it's recommended that they have a full physical every 1 to 2 years, depending on the control that they have of their diabetes. You're looking for end organ damage, all of those sorts of pieces. The one thing we did manage to get from MSP is an agreement that well baby visits, because we do mini full physicals on these babies. We don't do a rectal exam, but we do pretty much everything else. But the milestone monitoring, the milestone assessments, they agreed that it would be appropriate that we can bill complete physicals at the 6-month, 12-month, and 18-month visits because of the nature of that well child follow-up that we're doing. Full physicals can be billed up to once every 6 months when medically indicated. And that is the big thing you have to remember, medically indicated. If there is no medical reason, if you were ever audited and someone were to look at your chart and you documented a full physical and there isn't anything that indicates a medically necessary reason to do a full physical, that would be considered an inappropriate billing of that. When you are doing full physicals on women where pap smears are a part of that full physical exam, the pap smear is included as part of the full physical fee. You cannot bill the pap smear in addition to the full physical fee. When you're doing the well baby exams, the growth developmental monitoring, the big tip there is use that Rourke baby record, because it really is good at helping you to see what are all the pieces I need to think about at these different ages of the baby. So as I said, those can be billed at 6 months, 12 months, and 18 months. A baby that has come to you after having been delivered by someone else, and you may do a full physical, most of us do mini full physicals at 2, 4, and 6 months, but you can still only bill an office visit on it, even though you're doing essentially a full physical. You cannot bill a complete physical at that point in time because the fee code that has been billed by the doctor who is managing the patient in the hospital and doing the discharge is actually an equivalent of the full physical. So the full physical cannot be billed before 6 months under any circumstances. It'll be rejected because the time frame isn't there. Next slide, please. So our next poll is the case of Mrs. Sheddingweight. So Mrs. Sheddingweight is a 62-year-old female who comes in with unexplained weight loss and night sweats. You take a complete history, including her complaints. You review her past and present illnesses, making sure you've got everything up to date, seeing if there's any change in her family history, as well as obviously that functional inquiry. You do decide to proceed with a head to toe full physical examination to look for a source of infection or malignancy or other metabolic cause of all of the weight loss. What do you think you're going to build there? So we're going to put the poll up. So what fee code do you think you're going to bill for Mrs. Shedding Weight who is in her 60s? A 16101, a 17101, a 16100, or a 14560. We'll give you a couple of seconds, about 30 seconds or so to click an answer, and then we'll see where you're at. "93% of you are right. The 16101 is appropriate. The 17101, she's not in her 70s. So the 17101 is for 70-year-olds. The 16100, well, you could bill that. They're not going to reject it, but they're also not going to upgrade you to the full physical. You did the work. You did the full physical appropriately on a patient with weight loss NYD, and therefore you could bill the 16100. So we can close the poll there now. And go on to the next slide, which I think is the changeover slide again, but I'm going to take a quick look at some of the questions here. Let's see here. The complete physical exam with an ER visit. So we're not covering any of the emerge stuff. When you're in the hospital, these are all office related types of codes that we're talking about. There is a completely different series of codes that you use for emergency exams. The question, does head to toe exam include a joint exam? If the symptoms include things that might be there, like the Mrs. Shedding Weight, does she have a septic joint somewhere? So yes, you would be doing that. Under what circumstances is it okay to omit a GU exam when doing a full physical? Well, only when it's not appropriate, like the 90-year-old. Doing a pelvic exam in a 90-year-old is not really a good use of your time, would cause a lot of discomfort for the patient. And if you really think there's something going on in the pelvis, you're going to be doing other investigations to find that. So in general, if it's a patient who has, I guess the one time you may not do that would be someone who's had a woman who's had a total abdominal hysterectomy and bilateral oophorectomy, because there isn't any uterus and ovaries there. However, don't forget, when you're doing that vaginal exam, you're also checking to see what's happening with the bladder, what's happening with the rectum. And you're going to do a rectal exam as well, but you can sometimes feel things through the vagina that you may not feel as well with a rectal exam, just because you can often get a little higher with the vaginal exam. So it's about the clinical piece. Let's see here, how often we can do the physical exam. As I said, maximum of, or they have to be a minimum of 6 months apart. Again, I'm not going into the emerge stuff. Pelvic exams and rectal exams are required when it's appropriate for that person's age and sex. Absolutely. Can we justify billing complete physicals for all chronic disease? Not necessarily. You need to read the guidelines and see which are the chronic diseases that potentially have impact on other systems within the body. You know, that's why diabetes is one we often pick. Renal failure can, congestive heart failure will have more than one system impacted. So it really, you need to read the guidelines and be aware of that. Again, I'm not doing anything but emerge. So the prenatal complete physical, we're not doing any prenatal fees on these visits. That is a separate session. I know it's not part of this 6 series. I think that BC Family Doctors may offer more guidance on, may offer those. Wendy, do you know, is BC Family Doctors doing any additional things around prenatal stuff? Because that is a completely separate topic.
Yes,
So
I mean, at this point in time, they're not, but I'm pushing that they should be, because I get a lot of questions about, I get a lot of maternity OB questions.
Yeah. So let's see here. Anything else I haven't already kind of touched on here?
There's a couple ones that are interesting. If PAP is included in 0101, can you still bill a tray fee? The answer is no.
No.
And then if they downgrade you to a normal office visit, will they downgrade you to a normal office visit payment if they reject or decline your CPX? So your CPX is not going to, you may have done it for reasons that you shouldn't have done it and would not stand up to an audit, but unless there's been a CPX billed within the last 6 months, they're going to pay you. If they don't, I don't think they do downgrade you for that. I think they reject it, and then you're going to have to rebill it as an 0100.
But the main thing to remember is that relying on MSP to reject an inappropriate billing is not a good way to do business.
No.
Because they're just because MSP has paid something doesn't mean you billed it appropriately. So you need to be aware. It is your responsibility to ensure that you are only billing for the things that you have actually done under the rules.
There's another interesting question. You have a patient who attended the women's health program where she had a routine pap and breast exam, and then you see her later for a complete exam because she is a diabetic and needs and has other complex issues. So, I mean, I don't know about you, Kathy, but I certainly wouldn't repeat the pap.
No.
Probably not the breast exam. So, I would put in the notes, patient had breast and pap exam done in, within the last 6 months or whatever. And then, yes, I would still bill a complete.
But in addition to documenting that it was actually done by another provider within that 6 months time, within that time frame, I would also state, and patient has no additional complaints relevant to those systems. Because just because somebody had a breast exam 6 months ago doesn't mean there isn't something there now. So the pap test definitely, if the pap test was normal, if you got a copy of the pap test and it was normal, you do not have to repeat the pap test. But again, the pelvic and the breast exam, you don't necessarily need to do it if they're not have complaints related to it, but you absolutely need to include it in the documentation that it actually has been done. Therefore, you've deferred it as a result of the fact that it's already been done. The question about the male provider for the pap or pelvic to come in later, that gets into a bit of the gray zone. And, absolutely, I understand that there are some women who do not want a male provider to do the pap and pelvic exam for them. So if you are in a group as a female provider and you've agreed to do PAPs for some of the patients of your male colleagues, when you do the pap test, you are documenting and billing for it. The majority of medical indications for a true complete physical are usually in women who are getting very much beyond the childbearing age, where pap tests are going to only be once every 3 years. I mean, they're only once every 3 years, even when you're in childbearing age, but now if they're normal. But if it becomes a real pattern and there's a significant number, I'm not sure, Wendy, how would the patterns of practice committee and the audit look at that, given the patient choice to not have the pap test done by the male provider who may be doing the full physical otherwise?
I think, again, as long as the doctor documents it, I was prepared to do the PAP, the patient absolutely, refused, then you could still bill it.
Yeah, but document that you've made arrangements for them to have that PAP test.
Well, that you, not only that, but that you were prepared to do it, but the patient refused to have it done. So therefore, for the patient's comfort, you referred them, you asked another doctor to do it.
Yeah.
There is another question here that I get quite often in the billing questions. Can we bill MSP for pre-dental surgery for a complete physical? So the answer is that if the dental surgery is going to be done in a hospital under a GA, which it often is for pediatrics, yes, you can bill MSP. You may not need to do a complete physical, but what you do, you can bill MSP. If it's being done, in the dentist's office where under some anesthesia, but not a GA, no, you'd have to bill the patient privately. That would be more adults.
Again, the 14043 we're not talking about. That's mental health planning fee. That's at a separate session. Let's see here. Well, the one question that was on earlier about the per clinic or per physician was around the, that business cost premium that we get to pay for. There is more information of that on the Doctors BC website. That's not actually considered part of basic billing, but it is a part of our negotiated agreement. So I would encourage you to go to the Doctors of BC website for more of an explanation of it. I don't think the BC Family Doctors website really goes into it because it's a premium. It's an additional percentage upgrade that's paid by MSP that isn't actually billed by you. It's done in the background. So you can look at that on the Doctors of BC website.
So I actually, through tariff, I sat on the business cost premium working group when it was developed. And it is a bit of a problem for people who work in more than one clinic, because once you've hit your number, if you hit, they base it, how much they pay based upon you doing a certain number of services, they only pay it to one clinic. So if you worked in one clinic in the morning and you got up to your max there, the clinic in the afternoon is not going to get paid. You're not going to get paid it there because it's being paid. It's being paid to the physician's MSP number.
Yeah, and so it's probably only paid through one data center number, because if you're working in a different clinic, you've got a different data center number.
Mm-hmm.
There's, let's see, the one question here, finding out ahead of time about counseling visit limits have been reached. No, unfortunately, there is nothing there that can be done.
Well, you can't, you can call MSP. Like I was refused one time and I couldn't figure out who had done it. And I thought, is this a mistake? So I called MSP and they said, no, you can't get it because the 4th visit was done. And though they shouldn't have, they actually told me who had built it. So they will tell you if it's been reached, but I don't think they necessarily
they won't tell you who.
No.
All right. So now we're going to move on in the interest of time, because it's 5 after 7. We'll move on to the when is a visit more than a visit. And if we actually get through this with extra time left over, then we definitely can go back to questions related to this as well. So let's go on to the when is a visit more than a visit. So the office visit plus is what we're calling this. So there are times, the rules Wendy had gone over earlier, the multiple visit, multiple services, multiple duplicate services, and multiple visits earlier on. Now, within any one office visit, when is it more than just a visit? So if there is a procedure that is unrelated to the presenting complaint, then you can also bill for it, as well as the visit for the presenting complaint. If there's a lab test, absolutely, lab tests are billable in addition to anything else you do. If you provide a lab test in your office, you are able to bill for that. An unrelated service that is provided when the primary visit is billable to ICBC or WorkSafe, that's part of what we're including here. What we are not including here is information about uninsured services provided in addition to the visit, ICBC and WorkSafe. So those are not being addressed in this webinar at all. But the top 3 there is what I'm going to go through. So let's go to the next slide. So again, on the BC Family Doctors website, in their simplified guide to fees under procedures, injections, and labs, you'll see a great big long list when you roll down them of all of the different fee codes that fall under this category. Next slide. So as Wendy had indicated earlier, you bill the highest valued service fee at 100% and the lower valued fee or fees at 50%. Most of our procedures do attract tray fees, and I do have a couple of slides later on, I believe, that show what tray fees are with some with the codes, but not all of them. Some of them don't have a tray fee associated with them. So one of the more common ones is shown here. This is what it looks like on the BC Family Doctors website in the billing tool. The fee code is there, the description of it as well. Over to the right hand side, there's a little blue tab that doesn't show up on the screenshot that says more information. And when you click on that, you can actually go in deeper to read all of the billing fee notes that are there, all of the rules that are along it. And then you'll see the little red note as of October 1st of 2018. So literally for 2.5 years now, the mini tray fee, the 00044, is payable with every pap test, regardless of the type of speculum used. When we first brought this in back in, I'm thinking it was around 2000 maybe, 2001. Our then chair of economics went to the Medical Services Commission, which is where we have to go. If MSP in their pre-review agrees with what we want to present, then it just basically goes through the process, no problem. But when MSP opposes it, we actually have to go and tell the MSP people, or the Medical Services Commission, the commissioners, why we feel they need to approve our fee code. So when we first brought this in, our Mike Lawrence was our economics chair, and Mike actually took a bucket of really gross, dirty speculums with him and put it on the table and said, we have to clean and sterilize these. There's a cost to our practice for not only the time of our staff, but the actual things that we have to do. And they went, ew, and they approved it, but unfortunately originally only for metal speculums. So for several years, we unfortunately still didn't get paid to fill up the landfill. Or no, sorry, it was only for plastic speculums, not the metal ones. So we got paid to fill up the landfills, but not to clean reusable speculums. And then finally in 2018, we managed to convince them that that really wasn't a good thing for the environment, nor for our offices. It's not necessary. And so they agreed to expand it to every type of speculum, regardless of whether it was a disposable speculum or a metal speculum. So anyway, just a little bit of a side history lesson about what we had to go through to get to this point. Next slide, please. So some of the tray fees here, this is what the tray fees are. So there are three different tray fees. There's the mini tray fee, the 00044. There's the minor tray fee, the 00080, and the major tray fee, the 00090. You can see on the only one we've actually listed right here as to what it's applicable to is the mini tray fee. In the fee guide, there is at the back of the general section is the list of all of the specific procedure codes that are billable with which tray fees. Next slide. But what I've done here is I went through all of the GP procedures, the majority of the GP procedures anyways, and included when there is a tray fee, what the tray fee is. So you can see we've got pap and pelvic, and you must do both. Even though the evidence says the pelvic part isn't necessary, that's one of the things that we need to argue at MSP about, modernizing our fee schedule to actually align with what guidelines say. The IUD insertion has a major tray fee. An IUD removal does not have a tray fee with it. Doesn't have, even though you're using a sterile tenaculum to grab and pull out the IUD, there is no tray fee with it. The liquid nitrogen treatments, you can see here which ones are with which tray fees. The important thing to remember is just recently, actually over the last, I think, year and a half, it is shave or punch biopsies, which never used to have a separate code. They were only billable under an office visit with no tray fee, are now billable under the 13600 biopsy of skin or mucosa, or if it's on the facial area, the 13601. So the major tray fee is billable, even if you're doing a punch or a shave biopsy. And that's only been fairly recent.
As long as you're using a suture.
Yes, as long as you use a suture to close that wound. If all you're doing is putting steri strips on or just a dressing on it, you cannot bill the tray fee. The laceration repair, if it's without local, you only get the minor tray fee. If it's with local, you get the major tray fee. Even though the only difference is you're not using a syringe to punch in and get some local to freeze it, the tray is exactly the same. That unfortunately is the rules. Next slide. So these are just a list of all of the GP procedures. They're listed in the family physician procedures. They are listed in the family medicine section of the fee guide. Again, I've put with this what their actual relevant tray fee is, but all of this information, the tray fees are listed, as I said, at the end of the general section of the fee guide, and under each of the different, the 00090 and the 00080, it will list all of the codes that are billable in addition to those tray fees. Next slide, please. So pap smears are considered a procedure. So they are billable in addition to the office visit if a separate medical diagnosis is part of the office visit component. When it comes to injections, in particular vaccinations or allergy shots, they are not considered procedures, however, and so you're either billing for the vaccine, for the injections in people, for the injections, or you're billing the office visit. And I'll give you a little tip on that in a bit here. Immunizations for patients who are under the age of 19, so considered pediatric patients. Don't tell your teenager that when they're 17 or 18 that they're still considered pediatric. They won't like you about it. But from MSP's point of view, you're pediatric until you're 19 years of age. So there are medically funded, the publicly funded immunizations for patients who are under the age of 19 are billable in addition to visit fees. Next slide, please. I think we've got the list of them here. Oh, not yet. So first we'll talk about the injections. Ignore what the little head title is, because this is actually not about the pediatric vaccinations. This is about the other injections. So we have the one of the more common ones that, oh yes, it is. Sorry, I'm wrong. I see now. I didn't see the first one. I just saw the 0010. This is an example of the fee codes that are for patients that are under the age of 19, billable in addition to the office visit. Next slide. So this is the list of all of them, and you'll see we have 21, yeah, I think 21 different immunizations, and not all of them, of course, are injections. There are some of them that are the nasal spray. Doesn't matter. They're still immunizations. They are billable in addition to the office visit, provided the patient is under the age of 19. Next slide. Before we deal with this, the regular injection codes, because I don't think we actually put them in there. The intramuscular injection. So if you have someone who's coming in for a Depo-Provera shot or a B12 shot, then the injection fee is a 00010. The subcutaneous fee is a 00034, and that's the code. Most allergy shots are subcutaneous. So that's the code that we can bill for those. You can bill up to 3 per setting. So if you have a patient who has, let's say you have a 16-year-old who has significant allergies, and they come in for 3 different allergy shots all at once. So you put 2 in one arm and 1 in the other. You're actually better off to bill the 00034, the subcutaneous fee code, times 3 units for those 3 shots, because it will pay more than the base 0100 does for that patient's age. So you do need to take that into consideration when you are billing for injections.
I think you can actually bill up to 4, but I've never seen anybody get more than 3 allergy shots.
It's 3 for the 00010 and the 00034, but it is 4 for the pediatric immunizations. Don't ask me why it's different, Wendy. It is, and I think it's because, of course, the 12-month-old has 4 different immunizations that they get. So that I suspect is why, or they used to anyways when we first brought these in. So that's why the pediatric ones allow up to 4. But for the rest, for the non-pediatric injections, it's up to 3. Now, if they had those 3 allergy shots, plus this young woman had a Depo-Provera shot, you could still also bill the 00010 as well, because it's a different fee code. And so it's the 4th injection, but it's under a different fee code. So on to poll number 5. So in which of the following examples can something be billed in addition to an office visit? We've got a child with an earache and who has a wart that you need to apply cryotherapy to. We have a child with a wart for cryotherapy, but no other symptoms that you deal with. We have a blood pressure check and a pap test. We have the complete physical that includes a pap test. Let's go ahead and put the poll up, Katrina. And you can click more than one. So we'll give you a little bit of time to make your choices. And then we will see where we're at. Most of the questions that are coming up, I'll deal with afterwards. Let's see where we're at. The child with the earache and the wart and the absolutely yes. The child with the wart but no other symptoms, no, you can only bill for the cryotherapy. The blood pressure check and the pap test, absolutely, you get to bill the office visit fee code for the blood pressure check, and you get to bill the 14560 for the pap test with the 0044 tray fee. Additionally, the cryotherapy under the first one, and I believe that's actually on some of the next slides anyways, but the complete physical with the pap, no, you cannot bill the pap test in addition to the complete physical. The pap test is considered a part of a complete physical. So let's close this and go on to the next slide. Go ahead. There we go. And we'll just go through the rest of these. Go ahead. Thank you. So this is basically what I've just reiterated for you. So with the child with the earache and the wart, you're going to bill the child's office visit at 100%, and you're going to bill the 00190 for cryotherapy at 50%, because the base value of the 00190 is less than the office visit fee. Next slide. Another one, office visit and a procedure. Last year, this same woman that we talked about the contraception earlier, the 25-year-old Tasha Well woman, comes back to your office again to discuss the contraception, have a pap smear done. And the reality is at this point in time, you are going to check her blood pressure as well, because she's now been on contraception for a year. And we all know that contraception as a hormonal intervention does have some risks associated with it. So what fee code or codes are you going to bill? Let's put that poll up. Go ahead, multiple choice. You can, well, it's not actually multiple choice. Just pick one of them. Which is the one that most appropriately reflects what you would bill for these services. All righty. We should be getting our answers up shortly. So absolutely. I mean, you could just bill the office visit and the pap test and nothing else, but you're missing out on the value of the tray fee. You definitely can bill, but it would be half of the pap test, not the full pap test. Similarly, the second one is not correct, because the pap test, you would only bill it 50%. The third one is the one is half the pap test in addition to the visit. But whether you use a plastic speculum or a metal speculum, it is the last answer that is the correct answer there, because we got that changed in 2018. Next slide. So here comes the information for you, and the total billing amount is $52.65, because you have the office visit, $31.62, plus half the pap test, $15.81, plus the mini tray fee, $5.22, for a total of $52.65. Again, the note, the mini tray fee is billable with all types of speculums, whether they're the disposable or the metal. Next slide. Another one on procedures. So we have Mr. Sun Worship. He's a 60-year-old fair-skinned patient who is concerned about a skin lesion on his arm. It is irregularly pigmented. You've done your ABCDs, and it's got a bit of an irregular margin, and you're going, This might be something not so good. So you perform an excision of the lesion in your office. What codes are you going to bill to MSP for the excision on that day? And what is the total amount? So the total amount is, if you don't have a calculator and you don't have the value open, it might be harder to figure out. But the most important thing is, what are the billing code? What would you bill for Mr. Sun Worship? Now, is this a poll or is this just when we're going to give them the answer?
This is a give me.
Yeah, I think this is the one, one of the ones we're just going to
Yeah.
give you the answer. So we'll let you think about it for a second.
Oh,
Okay. And I'm going to, and there's a question on there about when you get a pathology back. So go ahead, let's pop this up. And you will go to the next, put in the answer. So we are going to bill the 13620, which is the excision of the lesion, not just a biopsy. So one of the differences between the excision code and the biopsy code is the fact that a biopsy, you are not taking the entire lesion out. You are taking a piece of the lesion out. Whereas with an excision, you are taking the entire lesion out. And this code is with the major tray fee, the 00090. So you can go ahead and put the billing amount up. But if when you get the pathology back on that, because we should be sending everything we take off of a patient should go to pathology. And if it comes back as actually being malignant, and then you seem to have got, whether you've gotten the margins or not, if it is actually comes back with a documented malignancy, unfortunately, I don't have the code, you would need to debit bill the 13620. So you're reversing the billing on the 13620 because there is a fee code that pays a little higher. I think it's around $9 or $10 higher than the 13620 for documented confirmed cancer. You cannot bill that code unless you have a pathology report that says, yes, this is cancerous. So that's the process you would go for if you billed it the day of the procedure, and then the next week you get back the pathology and go, oh my. Make sure that you get your MOA to debit bill the 13620 and rebill the code that's for the malignancy. It's the same tray fee, so you do not need to worry about rebilling the tray fee because that's, whether it's the 13620 or the malignancy one, they are both the major tray fee. That's the highest tray fee. Next slide. So that's the procedure part. Now, there was a couple of questions in there about procedures, but now they've kind of disappeared. I'll start at the bottom and I'm going to work up because it's just easier for me to see on my screen here. Billing the depot injection in addition to a visit in both adult or, oh, it went away. There it is. Or person less than 18. Depot Provera injections, the 00010, are not billable in addition to a visit. So if the only reason the patient came was to have that shot, whether it's given by you or by your nurse in practice, all you should bill is the injection code. If you've had to deal with something else with them, maybe they had other questions around the contraception, or they'd had a little bit of spotting, so you had to go through your assessment that way, then you would bill the office visit instead of the injection fee code. So you cannot bill, the only time the injection codes are billable in addition to the visit is for pediatric children, pediatric patients under the age of 19 with a publicly funded immunization. Any other injection codes are not billable in addition to the office visit. It's one or the other. So the injection code for an IM injection is a 00010. The injection code for a subcutaneous, which is what most of the allergy shots are, is a 00034. Is it appropriate to be charging privately for those adult injections? Not if it is a medically necessary service. You cannot bill the patients privately for anything that is not medically necessary. You can only bill patients privately for uninsured services. We are not going into uninsured services in detail. the 100% and 50% only for Office Plus? No, or does it apply to multiple injections? No. So when you were doing them, like I said, the patient who's come in for 3 allergy shots, you're billing the 00034 times 3 units. It's not at any kind of reduced rate. They pay all 3. They pay the amount for the full amount when it's the injections being billed instead of the office visit. So the 100% and 50% is only when you are billing different procedures that have different codes. When you are billing multiple procedures of the same code, there is on your billing screen a little box that says how many units, and that's where you put the 0.5 if you're going to bill a 50%, or if it's multiple injections, you put the 2 or you put the 3, depending on how many you've been given, up to the maximum of 3. Let's see here.
There's one about what's the billing code of punch biopsy without a suture. So that's going back to before before it was changed, you could only bill the 0100. And so if it's a punch biopsy without a suture, nothing has changed. It's still the 0100.
An office visit with no tray fee.
Exactly.
So the question about the how to bill the PAP billed in half, like I say, on your billing screen, there is a little section there which says units. You put in 0.5.
There's also something that's confusing in one of the slides, and somebody asked a question about it. So the tray fee, you can bill a tray fee with any type of speculum used for a PAP. If you're doing a vaginal exam and no PAP, you're using a speculum, you cannot bill a tray fee. Yeah.
The tray fee is only when you are billing the 14560, the fee code for PAP and pelvic. That is the only time that with the speculum use, it is billable.
And there seems to be, there's always this confusion about immunizations. So what I always try to say when people ask a billing question is that if the vaccine that you're giving was publicly funded, then that's considered medically necessary by MSP, and you can bill that to MSP. If the patient comes in with Hep A because, in the past they were going traveling, that is not, they bought it. And the same with the Shingrix. You can charge, you can decide to do it for free, but you can charge the patient an injection fee privately.
Yeah, so any of those travel injections, flu shots in people who are not eligible. I think this year they allowed us to bill the flu shot on just about everybody, if I remember
Yeah,
right.
they did.
Just because of the situation, but usually the flu shot is restricted to the elderly, people with chronic conditions, that respiratory conditions in particular, and so then you could bill it to MSP. But if you had someone who wasn't eligible, then they would you'd have to bill them privately for that. Now there's a question there about the Adacel with pregnant women. If you're giving that at the time of your prenatal visit, then it's part of your prenatal visit. You cannot bill additionally for it. If you are, I remember a few years ago when with the H1N1 shots, and they really wanted to get pregnant women vaccinated in our maternity clinic. We had a Thursday morning where there was no doctor seeing prenatal visits, and I said, okay, I'll come in and be Nurse Kathy for the morning, and Nurse Kathy will give all of these injections, and I will just bill the injection fee because that's the only purpose for the visit that day. So if the only purpose for the visit is to give them the Adacel shot and you're not doing a prenatal visit or anything else for them, then you just bill the 00010, the intramuscular injection code, and that's it. But if it's being done at the same time as their prenatal visit, which is what most of us tend to do, then it is included as part of the prenatal visit.
And I think something else where people get confused is that when you're doing immunizations in the pediatric age group, you can definitely bill a visit. Say you saw the patient for the 2-month check and the kid had a bit of a cold or whatever, and the mom didn't really want them to have the shots, and they came back 2 weeks later and you were just doing the shots, you can still bill a visit in the pediatric age group.
Yeah. So there was another question again about Depro injection in 20-year-old with a visit. Well, you're billing for the visit if they've come in for a visit, and oh, by the way, I'm also giving you the Depot shot. The Depot shot is part of the visit. So it's the only time you bill injections in addition to visits is publicly funded immunizations in people, children, well, young adults, people under the age of 19. Otherwise, everything else, you're either billing for the injection or you're billing for the visit, depending on the nature of what that's like.
Except for it was different, you know, they changed the rules for flu shots this year. And when we get to the COVID vaccine, that's also different.
So there
those
have
are
been
both
some
those are both temporary.
very specific temporary changes, the exceptions to that rule, but in general, and Wendy will go over those as well. So let's go on to the office lab tests, and then we'll come back to see if there's anything else that we need to do. So next slide, please. So in addition to the office visit or the procedure, if you provide any office diagnostics, the most common one is a urine dip. So that would be the 15130. And the stool, the urine pregnancy test, the 15120. So this is why we could not give the 50-year-olds their 151 for their age differential codes, because the 15100 is already the glucometer test. The 15120 is already a urine pregnancy test. There isn't a 15101 that I'm aware of, at least not on this list. But like I said, I think there is, but it's just not on this list. But these are the codes. So if you have provided any of these services to your patients in the office, they are billable in addition to the office visit. Next slide. So that was a single slide comment. Here's poll number 8. We have Jenny, a 30-year-old, comes in with dysuria and urinary frequency and hesitancy for 24 hours. She's on examination, a little bit of suprapubic tenderness, no fever or CVA tenderness. Her urine dip in the office is positive for leukocytes, nitrites, and blood. So you diagnose her with a UTI and give her a prescription for your antibiotic of choice. What billing codes would you use? Let's go ahead and pop that poll up.
This is actually a gimme one.
Okay, it's a, think about it for a couple of seconds. What do you think you're gonna bill? We'll count down 10, 9. I wish this is where we should have the Jeopardy song. Dun 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 dun. Okay, let's show them the answer. Okay, there we go. So Jenny is 30, so an office visit is the 0100. The urine analysis is a 15130. Next slide. So now we're going to go into unrelated services. Now, again, we're not talking about uninsured services. We're not talking about ICBC or WorkSafe. There's 2 very specific codes that when you have provided a patient with a primary visit that is either ICBC or WorkSafe, and the, oh, by the way, doc, can I get my blood pressure checked and my blood pressure pills, as an example. There's 2 very specific codes that allow us to be paid for both. So let's move on to the next slide. So first of all, when the patient's primary purpose for coming in is related to their car accident, you're going to bill their 0100 age equivalent to MSP, indicating ICBC as the insurer, but oh, by the way, I have a sore throat or I need my blood pressure checked. So do you then provide the medical visit that is not related to the car accident? And so in addition to the 0100 that's billed indicating ICBC as the insurer, you also bill to MSP, go make sure that the insurer is back to being MSP, and you can bill the 13075 for that, oh, by the way. Next slide. So on your billing, in your billing software, there is a place where you can look to see what is the insurer. So you will want to change it from MSP to ICBC to bill the 0100, and then you want to change it back to MSP for that unrelated complaint to bill to them. Make sure that the diagnostic codes are also different. So for example, with ICBC, most of them are musculoskeletal. You might use the 781 as the diagnostic code there. But if they happen to have had, oh, and reassessment of my sprained ankle from 2 weeks ago, if that's the additional thing to check, then go to one of the ICD-9 code helpers online and find out what is the very specific diagnostic code for a sprained ankle. Because if you do not use different diagnostic codes, they will reject the 13075. They must be separate diagnostic codes. Next slide. So similarly, when the patient's primary reason for seeing you is a WorkSafe covered injury, you're going to bill the 0100 plus the form fee if it's appropriate, with WorkSafe as the insurer, and the, oh, by the way, can you do this other thing that is not related to their WorkSafe injury? Then you can bill the 13070 for that MSP medically necessary unrelated service. You will notice that the value of the 13070 and the 13075 is actually 50% of an 0100 visit. So it's already predetermined that it's already that 50%, but this is the only case where you have two visit type things that are actually billable on the same patient. Again, making sure you have the correct insurer and different diagnostic codes. Next slide. So here we have poll number 9 with Ron. He's come to the office complaining of neck pain after he was rear-ended the day before. He also complains of a sore throat that's been getting worse. Okay, so both of these are up in the head and neck, right? So remember this. You take the details of the car accident, examine them, provide appropriate advice, determine that it's a musculoskeletal issue. You also examine his throat and ears, diagnose a viral infection, and give him some symptomatic management advice. What do you think you're going to bill? Again, this isn't a poll. This actually is give you a little bit to think about it. And
It's actually a poll.
Oh, this one is a poll.
It is.
Darn, you confused me, Katrina. Okay, here comes the poll. And you can choose more than one thing on this. In fact, hint, you should choose more than one thing on this now. Bum, 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 ba-da-da-da-da. Can you tell I like Jeopardy? Okay. Let's see what the answers are that are coming up here. So you're going to bill, yes, the 0100 to ICBC as the insurer, and the 13075 to MSP for the unrelated sore throat. So again, make sure that you are using different diagnostic codes. Do not use 784 for both of them because it's about the head and neck area. You'll get the MSP unrelated one will get rejected. They must have separate diagnostic codes. Go ahead, we'll close the poll and go to the next slide. There we go. We're kind of running a little low on time, so we won't go into this question. We thought we'd ask you if you thought of any other insurers and how you might do that, but that really goes more into the uninsured services, so we won't do that one. So now I'm going to take a quick look to see if there's anything else that we should go here. Is there any limit for number of different or unrelated procedures you can visit? So liquid nitrogen, intra-articular joint injection, punch biopsy, and Botox. Okay, so first of all, the intra-articular joint injection and the Botox injections, I believe, are not billable in addition to office visits. The punch biopsy, if you've put the suture in, is yes, billable in addition to the visit fee, as is the liquid nitrogen. So in this example, of those 5 things you did, I believe only 3 of them actually are billable because only 2 of the procedures are billable in addition to the office visit. So I know that the biopsy component for the dysplastic lesion, the 13600 is the non-face one, the 01 is the face one, is actually a higher value than what the office visit is. So the punch biopsy, the 13600, is the one I would bill at 100%. I would bill the office visit for the blood pressure check at 50%, and I would bill the liquid nitrogen, the 00190 at 50%. In addition, the punch biopsy, the 13600, is eligible for the major tray fee. So you would bill the 00090 major tray fee in addition. You do not get to bill another tray fee because you've done liquid nitrogen. You're only one tray fee. No matter how many different procedures you may do, you get one tray fee, and you always use the whichever the highest related tray fee is that's appropriate for that. So that's on that one. The multiple injections depends on whether it's intramuscular 00010, subcutaneous 00034. If you do a pelvic exam without a pap test, that is just an office visit. That is a regional examination. Is contraceptive discussion included in the pap visit? I'm going to let Wendy answer this because that's one of the things that sometimes has come to patterns of practice in the past. Wendy, the question is about the contraceptive discussion included with the pap visit, just like our well woman, our Wendy well woman, I think she was, if I remember right.
No, Tasha.
Oh, there you go. Okay.
So, I mean, I think it has come to patterns of practice before, and I have to be honest, I haven't been on POP for such a long time. I don't remember the answer. I mean, you should be able to bill it because it is different. The PAP is being done to rule out cancer, the contraception, it's different.
Yeah. And the one thing though that I would say that would justify it being billable as well is that you really should, so first of all, you should only be giving your birth control pill prescriptions for a full year. There's no medical need for bringing the patients in every 3 months just so you can bill an office visit. So if you're going to do that at the same time as you're doing the pap test, you should be checking somebody's blood pressure once a year if they're on birth control pills because they're on hormonal manipulation. So you've had to check their blood pressure. Well, that is part of an office visit. So that is part of what would justify billing both the office visit plus half the pap test and the mini tray fee for the pap test component of it.
So there's a couple of questions that you might want to answer about the 13070 and the 13075. Nope, they disappeared.
They just moved somewhere.
Yeah, they moved, so I got to get back up to them.
Oh, there they are.
Yeah,
What's
so
the difference between 13070 and 13075? So the difference is who was the primary visit related to? One is when the primary visit was for MSP, was for ICBC, and one is when the primary visit is WorkSafe. So the oh, by the way, which one you choose depends on what the primary insurer and purpose of the visit was. Was it WorkSafe or was it ICBC? And I have no idea why MSP insisted on having 2 separate codes. Absolutely no idea. But that's what they insisted on when we first brought that in well over a decade ago.
Yeah. So another question is, can you bill the 13075 during a driver's medical that the patient pays out of pocket for? Well, you won't get paid for it because you haven't billed anything to ICBC that can be seen by the billing agency. You have to, so you would just bill an 0100.
Yeah, because if the patient is paying, again, so this is uninsured services. If the patient is paying for a privately for the driver's medical, so they are not one of the medically necessary driver's medicals, which is a whole other conversation. But the patient, whether they're over 80 or they're a commercial driver, and they're paying you privately for the visit for the driver's medical, but they, oh, by the way, I also have this, and can you check it? And that is a medically necessary service. So you actually can bill the 0100 at full rate because that is separate from what the purpose of the driver's medical is. So that is a part of that whole uninsured services conversation as well.
So maybe we should go on to the COVID-19 now.
Because we're down to 13 minutes. So I will hand over to you.
Okay.
And there we go.
So there's 3 new COVID-19 fees, and they are specific to suspected or active COVID-19. So if you're doing an office visit for COVID-19 and you're doing the test, so that's in person with the patient, with the test, you bill the 13701. If you're doing an office visit for COVID-19, the person suspects they have COVID-19, and I guess you either don't have the test and you can't do it, or you don't really believe they do, then you would bill the 13702. So it's the only difference between the two. They're both in-person visits, they're both about COVID-19, but you're doing the test and the other without. I would presume you could also bill the 13702 if somebody has confirmed COVID. So the 13708 is for, you're the GP and you're communicating with a specialist and or an allied care provider. It's strictly a conference about COVID-19. So it's a conference about the patient with the specialist or the allied care provider. And these 3 fees are specific to clinical COVID-19 related scenarios. So you've got to use, in order to get paid, you've got to use the ICD diagnostic code C19 for all 3 of these fees, because that says that it's about COVID. Next slide, please. So, well, they're not that new anymore, but the COVID-19 fees for in-person visits are the 13701 and the 13702. Again, use that diagnostic code C19, but they're only for in-person services. Next slide, please. So just to reiterate this again, the 13701 is payable for patients with suspected or active COVID-19 symptoms only. The COVID-19 testing must be performed by you at that time. It's not intended for providing general information on a viral infection. Well, I think that's pretty obvious because you're not doing the test. Not payable in addition to any other office visit to the same physician, to the same patient, same day. But it is billable in addition to a telehealth service on the same day for the same patient by the same or another physician. And that's important because other telehealth visits, like if you were talking to somebody just doing a regular telehealth visit, and then you decided, oh no, this person really needs to be seen face to face, and it has nothing to do with COVID, you can bill either the telehealth or the office, but you can't bill both. The only way you can bill both is if it's about COVID. Next slide, please. So the 13702, it's payable for patients with suspected or active COVID-19 symptoms only, not intended for providing general information on a viral infection. You'd bill the age appropriate 0100. It's not payable in addition to any other office visits to the same physician for the same patient, same day. But again, it is billable in addition to a telehealth service on the same day for the same patient by the same or another physician. Next slide, please. So the 13708. So again, it's a fee for communication with a specialist or allied provider. So it would be, you would think about it somewhat similar as the 14018 and the 14077, but there's fewer constraints on it, meaning that there's no minimum time requirement. You know, for the 14077, it's 15 minutes or the greater portion thereof. So no minimum time requirement. You do not have to put start and end times. There's no urgency or response time, which there is for the 14018. And it's billable by any family practitioner, regardless of whether you've billed the 14070 or the 14071. So it replaces the 14077 and the 14018 for communicating or conferencing with a specialist or allied care provider about a patient related to concerns about COVID. It may not be delegated, and it's billable in addition to a same-day visit. So next slide, please. It's payable to the family physician who participates in a two-way telephone or video conference communication with a specialist and or an allied care provider about a patient regarding COVID. It cannot be delegated, so no claim may be made where communication is with a proxy for either provider. So it has to be the family physician on one end and the specialist and or the allied care provider on the other. It is, again, payable in addition to any visit fee on the same day, be it face-to-face or telehealth. It's not paid, so this is very similar to 14077. It's not payable for communications which occur as a part of a performance of routine rounds. So if you had a patient who's in hospital with COVID, it was routine rounds and you were talking to the specialist about how the patient's doing, is not, you can't pay for it, you can't bill it. Or communications which occur as part of regular workflow within a physician's community practice. So that's the same rules as the 14077. It's not payable in addition to 14018 or 14077 on the same day for the same patient. It's also not payable to physicians working under an alternative payment funding model whose duties would otherwise include provision of this service. Next slide, please. So to recap, the 13708, it replaces the 14077, the 14018 for communicating or conferencing with a specialist and or the allied care provider about a patient where there's concerns about COVID-19. And the next part is very important. It's billable by all family practitioners. You know, to bill a 14077, you've got to be the MRP or a locum for the MRP. No minimum time requirement, no start end times required, but may not be delegated and billable in addition to a same day visit. Next slide, please. So COVID-19 immunization. So far, I think very few of us have been able to bill any of these because, we haven't been doing COVID-19 immunization in our office. So for the mass immunization clinics that are coming up, you will not be billing these fees either because they're going to be paid by sessional. So, but these fees they're ready to go once we are able to start providing COVID immunizations in the office. So there's three fees, and the first one is the 10042, and so it's immunization with a visit. So this is quite similar to what they brought in for the flu shot this year. So this is going to be payable for a COVID-19 immunization, and again, you've got to use that fee code, the ICD code C19, and it's payable in full with a visit. This is for an unrelated visit. So if the patient comes in, they have hypertension, it's not just the only reason they're in there is for that COVID-19 immunization. And so that it says that the primary purpose of the service is for immunization, bill the fee item 10043 and 10044 if applicable. So if the patient is strictly coming in to get the COVID-19 immunization, you bill 10043. And again, you have to use that ICD code C19, and it's not payable with a visit. Now, BC family doctors realize that the COVID-19 immunization is a brand new immunization, lots of questions from patients about it. So we really felt that even if the patient was only coming in for the COVID-19 immunization, it's very unlikely that you're not going to be spending extra time with that patient for questions or concerns they have. So that's why the 10044 was brought in. But if your patient's totally fine with the COVID and they're just walking in one door, getting that immunization and walking out the other door, it's just the 10043. So the 10044 is billed in addition to the 10043. It's payable for an extended COVID-19 immunization. And it's paid only in addition to 10043, where the physician time with the patient exceeds 10 minutes. Start and end times, because it's a time-based fee, start and end times must be entered in both the billing claim and the patient's chart. It's not payable for immunizations provided as part of a health authority immunization program because they're going to be paying you sessional. And it cannot be delegated to a nurse or other employee of the physician's practice. So, and you also cannot bill the 10044 in addition to the 10042. Next slide, please, if there is one. Okay, so this is just showing you, this would be what you'd find if you went into the simplified guide to fees. So respiratory immunization, 19 years plus. So 10040, which is the 543, which is equivalent to what you got for the extra for the flu shot if it was an unrelated visit this year for adults. And then the 10041, and that would be just for the in and out the door for $14. Next slide, please. Send us a billing question. Okay, so if you belong to BC Family Doctors, you can send us a billing question and that will come to me. Next slide, please, if there is one.
And Wendy, that respiratory injection, whoops, let me put my video back on.
Oh, is that was strictly for the flu?
That one's for the flu shot
Yeah.
or pneumococcal.
Yeah, and so that one, the only thing you're going to be doing anymore, sorry about that, the only thing you're going to be doing anymore is the pneumococcal. And that only applies to the pneumococcal vaccine that is publicly funded. If the patient's getting the pneumococcal that they bought at the drugstore, you can charge that privately. And these fees are temporary. And so whether or not they will exist next year is up in the air. Sorry about that.
The definition of them is they're temporary until the public health officer calls an end to the COVID crisis.
Yep.
But believe me, it's part of our conversations with the ministry.
Oh, I know. So I don't know if there's any other questions about COVID.
There's a question there about 13702 is confusing as Office for Other Telehealth Services was identified as being outside of the hospital, whereas the 13702 is not restricted to out of hospital. It's no matter what your location is for the 13072.
Okay.
13702.
Okay. So it looks like everybody's got the COVID billing down pat.
What about publicly funded immunizations for adults, such as the pneumovax, as we said, the publicly funded pneumovax right now is under that respiratory code. However, a year from now, it may be under the same rules I just talked about, that if you give them an injection and you've seen them for something else, then it's covered as part of the office visit. So you do not get to bill the injection code. Or if all you saw them for was the injection, then you bill the injection code. But right now, specifically with the respiratory immunization, the publicly funded pneumovax, that does have this same kind of a code that could be billed in addition to the visit. I know it's confusing right now. And we are having conversations to see if we can get them to make this permanent. You know, the next step through our door is to make sure that we get them to do the same thing for all of the immunizations that are publicly funded, not just the narrow focused ones. But right now, it's focused. There's a question about, can you bill MSP for unrelated ICD code and also bill privately ICBC during COVID? You don't have to. So the visit for ICBC injuries is always covered through MSP. The payment for it is behind the scenes, where ICBC reimburses MSP for all of those visits that you've indicated it's their responsibility. So you wouldn't bill the patient for that private assessment of a car accident injury. And if they have the, oh, by the way, then you're billing the appropriate, we'd have to go back to the slide because I never get them right, which is whether it's the 13070 or the 13075, but whichever one is the appropriate for the motor vehicle, in addition to the motor vehicle visits. Now, remember though, that any uninsured services like medical legal reports and that sort of thing are billable in addition to any visits that you provide to the patient. But again, the details of that is not part of what we're covering today. Now, there's a question at the end about clarify whether there are any main pro credits for this session. That I will speak to, and because no, there are not. Main pro credits are not applicable to any kind of sessions that are around billing and making more money. Or unfortunately, they're very strict, and I know this because when I do my sessions for Jewel, we have to be very clear that they can only access main pro credit hours when we're talking about broader practice management things, not billing stuff. So the College of Family Physicians is very specific. Anything that your session is only about cannot be included. Now, in days, there are some of the divisions may offer a chronic disease management webinar, and a small part of it may be about what to bill for those patients, and that would be claimable for your main pro credits, because the main part of the content is about managing the patients, with only a small part of it being about and how to get paid for managing those patients. So that's, in a simple answer, no, sorry.
All right, well, that pretty much brings us to our end tonight. Thank you very much, everyone, for attending. And of course, thank you to our physician billing educators, both Wendy and Kathy. We hope that you found this webinar to be helpful and informative. However, our time is now up, and there's still quite a few questions remaining that we just won't be able to get to tonight. We did flash up, and I will put into the chat box, the BCFD ask a question. If you are a member, you can utilize that particular avenue to ask them questions. And there's a few other resources. This tonight is recorded, and I will be sending it out within a week's time. The links to view the recordings, along with any of the hyperlinks that were shared in the chat that were discussed throughout. And a reminder, there's a survey that will pop up when you leave the webinar, and we ask if you can complete this to provide us with your feedback. So wishing you a good rest of your evening, and I'll wish you all
just
a good
do
night.
one quick thing, just because the last question there I'm going to ask Wendy. If
Sure.
you do an IUD removal and a PAP at the same time, you only get to bill for the PAP test, right?
That's right.
There we go.
You can bill for one of the two, but you would bill for the higher,
Higher
value
value, which I believe is the PAP test,
with the PAP, because you've got the mini tray fee too.
provided you've also done the pelvic.
Yeah.
All right, everyone. Thank you so much, and have a good evening.